Hello and welcome to Talking General Practice, the podcast from GP Online. I'm Emma Bauer, the editor of GP Online. Coming up on the podcast today, I'm joined by our deputy editor Nick Bostock to talk about the latest news affecting general practice. We're talking about how the GP workforce is changing across England and which areas are moving quickest towards what's considered a safe GP-patient ratio. We'll also be discussing what we know and don't know about this year's GP contract, rounding up a number of stories we've written recently that cover issues including staff pay rises, what could happen with PCNs, the GP funding formula review, and what forthcoming guidance on neighbourhoods could mean for primary care and the NHS. And later on, our senior reporter Kimberley Hackett is going to join us to talk about our good news story, which is about the winners of the London General Practice Awards, which were presented in the Houses of Parliament earlier this month. Managing a practice right now is a balancing act. That's why a team subscription to GP Online is a smart investment. Not only do you get access to GP Online, your team can access MIMS for their prescribing information, MIMS learning to manage their CPD, and GP Business for practice management advice. That means expert advice on red flags, news updates, HR, finance and contracts to keep your practice running smoothly. Support your staff and protect your business. Check out our team subscriptions at GPonline.com. So Nick, first up, let's talk about the GP workforce. We've spoken about this a bit on the podcast recently, and there's been an uptick in the GP workforce in England over the past year, hasn't there?
There has. The number of fully qualified full-time equivalent GPs at the end of 2025 was about 2% higher than at the end of 2024, and it was about 5% higher than at the end of 2022. So that figure is moving in the right direction. But I think what's maybe more important is that as a result of that increase, the number of patients each GP is responsible for on average, number of patients per GP, is falling. A couple of years ago, the number of patients per GP in England crept over 2,300. But by the end of 2025, it was down to 2,220. So that's good news. But those numbers are still nowhere near where they need to be to make general practice safe with manageable workload. We've talked a lot about the idea of a safe limit in terms of the number of patients a full-time equivalent GP can manage. 1,800 patients per GP, is often quoted as the safe limit. But more recently, the BMA has said that by 2040, it wants to move towards 1,000 patients per GP. That lower number reflects the fact that the average patient is becoming a lot more complex as the population ages. It might be the kind of shift needed to make it possible for general practice to take on more work from hospitals in future.
So this week on the website, you've been looking at the regional picture of how the workforce has changed, haven't you? What did you find?
As I mentioned, the number of patients per GP nationally has reduced as the workforce grown a bit faster than the number of patients registered with GP practices. But there's a lot of variation between ICB areas across England, both in terms of how many patients GPs are responsible for on average and in terms of the direction they're moving in. So nationally, patients per GP dropped in 2025, as I mentioned, but 14 out of 42 ICB areas actually saw an increase. Mostly it's fairly small, but they're still seeing a rise. And the starting point in different ICBs varies massively. In the most underdoctored ICB, there are more than 2,700 patients per GP, whereas in the least underdoctored area, there are fewer than 1,900 patients per GP. So that's actually much closer to that 1,800 per GP safe limit talked about in the past. One thing I found, though, is that over the course of 2025, the gap between the areas with most and the fewest patients per GP is narrowed by quite a lot. So what that means is that areas that are the most underdoctored seem to have managed to bring in GPs faster than areas that are the least underdoctored. So inequality in GP provision in that sense has narrowed a bit. The two ICBs that had the most patients per GP at the end of 2024 both managed to reduce patients per GP by more than 200 over the 12 months to the end of 2025. So that's 5 times the national average reduction in patients per GP over the year. And it meant that England moved from having a 56% gap at the end of 2024 between the most and least underdoctored areas to a gap of 47% at the end of 2025. So it's still a really big gap, but it's moved quite far in the right direction.
So which areas are doing the best and the worst on this?
Those two ICBs I mentioned that had the most patients per GP at the end of 2024 are Bedfordshire, Luton and Milton Keynes ICB and Kenton Medway ICB. So Bedfordshire, Luton and Milton Keynes moved from having 2,916 patients per GP at the end of 2024, which was by far the highest in the country, to having 2,678 at the end of 2025. So it's still the second highest in the country on that measure, but it's a really significant change, more than 8% drop in patients per GP in just that single year. A couple of other areas managed similar changes. So Kent and Medway, Frimley ICBs, both saw patients per GP come down by 7.8% for one of them. But there are some other areas where patients per GP, that measure is still going the other way. Lincolnshire ICB, Mid and South Essex ICB both saw an increase of about 3%. And then there are a few others where it's a half a percentage point or 1 percentage point increase, that kind of thing.
Do we know, why the GP workforce has grown? We talk about these workforce figures a lot on the podcast. Is this growth to do with the ARRS, of GPs being added to the ARRS, or is it something else?
We know that ARRS is a big factor. In full-time equivalent terms, the highest figure recorded in any single month for GPs recruited through the ARRS was just under 1,450 in October last year. That's probably the most recent figure we have that's reliable, just because claims from PCNs come through with a bit of a delay, so they're a bit behind the sort of standard workforce figures. And the government says it can't provide a figure that combines ARRS GP numbers into the overall GP workforce. But we know that the ARRS GP numbers bleed across significantly into that overall count. But I think what we can see from the data for areas like Bedfordshire, Luton and Milton Keynes, for example, is that the really big reductions in patients per GP have been achieved by recruitment over and above the ARRS. So salaried GPs in that ICB area rose by 26 in 2025, and the ARRS figure to October is a suspiciously identical 26. So maybe ARS is entirely responsible for the rise in salaried GPs in that area. It's not necessarily the case, but it's plausible. But practices in that area also recruited an extra 8 full-time equivalent partners in that time. And that really bucks the national trend. And obviously those GPs can't come through ARRS because partners are not something you can recruit through ARRS. And then in some other areas, we can see that salaried GPs overall have risen by a fair bit more than the ARRS numbers for those areas. So that suggests practice level recruitment is responsible for the increase in GP numbers up to a point. And that's really welcome at a time when we know many practices are struggling to afford to take on extra GPs because of funding constraints. One thing I'll just mention, though, with all of this is that while it's really welcome to see that numbers of patients per GP are dropping across the country, particularly the fact that it's happening in areas that are the most underdoctored, the fact that a lot of recruitment has come through ARRS means there needs to be a note of caution. GPs can only be hired through ARRS in their first 2 years after qualifying. So these are GPs who don't have the same experience as older GPs who've been around for longer, many of them partners who we know are leaving general practice. So there's an element of not replacing like with like. Another factor is that GPs coming into ARS roles are often spread across multiple practices. And all that means that while they're helping shift the ratio of patients to GPs, they may not be having the same impact on workload and on the workforce that they would if we were talking about an influx of more experienced GPs based in specific practices.
Yeah, that's a really good point, that. So let's move on to talk about the GP contract for 2026-27 and what's going on with neighbourhoods and how that might shape up over the next couple of months. We're on pretty dodgy ground talking about some of this because we're expecting an announcement fairly imminently about the contract, aren't we, Nick? So everything we say could be out of date quite quickly.
Yeah, the BMA GP committee is predicting a contract package will be announced towards the end of February, so we're looking at sometime next week, potentially. We've also had an indication from the NHS England side that's the sort of timescale we're looking at. At a board meeting in the first week of February, a senior official talks about not being able to say much about changes coming in the contract because it wasn't going to be public for the next couple of weeks. Again, that points to the end of February. We're also expecting some guidance on neighbourhoods around the same sort of time, but the sense is that the actual contracts might take longer to materialise. So some of the uncertainty we've talked about recently on the podcast, questions like how will neighbourhood contracts and funding overlap with PCNs and GP practices? Some of the uncertainty around that looks like it may not be resolved for a little while to come.
So we know the way the contract has been developed this year has been different from usual. We've talked about that on the podcast quite a few times. So it's not been a negotiation with the BMA. It's been a consultation process where lots of stakeholder organisations have had the chance to feed in their thoughts and then meet with the team at the Department of Health and Social Care to discuss their views. Because of that, it's really up to the government when it decides to announce the changes. You wrote a story this week, Nick, that had some indication of a couple of the things that we could expect to see in this year's contract. Can you explain a bit about that?
I mentioned the NHS England board meeting just now, and there are a couple of clues about what might be coming in the contract from that. Dr. Amanda Doyle, NHS England's primary care director, she said that the contract for next year would bring a stronger focus on diabetes and child vaccinations in particular. So why these two things? We know from the 10-year plan that the government wants to ramp up prevention. That's one of the three big shifts that the 10-year plan talks about. And in fact, I think I mentioned on the last news podcast that a minister had said in a written answer to a parliamentary question that changes to the QOF for next year would focus on prevention and delivering the 10-year plan idea of a shift to prevention. But when it comes to both diabetes and childhood vaccinations, the NHS is falling short at the moment. The National Diabetes Audit talks about 8 key care processes that everyone with diabetes should have completed every year. Those are things like blood glucose measurement, BP measurement, checks on BMI, kidney function, things like that. But as things stand, only 58.2% of people with diabetes had all 8 of those processes recorded in 2024-25. So that's a massive gap in terms of prevention. And then on child vaccination, the government launched a PR campaign just this week to try and increase uptake. But as things stand, the UK is well short of the World Health Organization target of 95% coverage. And actually, it's getting further away from that target on some measures. The UK's now lost its measles-free status. That's because of a big outbreak in 2024. But at the start of this year, we've seen an outbreak of measles cases in London, which has the lowest vaccination rates in the country by a distance. So improving uptake of child vaccination is a big area where prevention can get better. And one thing we might look out for the contract package in 2026-27 is how the government is prepared to incentivise practices to achieve higher rates of vaccination. The item of service fee for child vaccination went up this year, while the fee for other jabs didn't change, and NHS England said it would be monitoring the impact that has, as in whether upping the fee for practices actually leads to an increase in vaccination rates. The BMA has actually called for all payments and fees for GP practices to rise in line with inflation. That was part of a list of contract demands it put out at the end of last year. And it says item of service payments for vaccinations should rise to £13.48 to reverse real terms losses in the payments that practices receive over recent years. And on that subject, we reported this week that some practices are considering actually dropping out of the flu vaccination campaign for the year ahead because of funding erosion. So the item of service payments practices receive for flu jabs has not changed since 2019-20. So the payment per jab has been frozen at £10.06 for 6 years. And what that means is that in real terms, what practices are being paid has dropped by more than a quarter. And the BMA wrote to the Chief Medical Officer this week to say that some practices now feel it may not be financially viable for them to take part in the financial year ahead. And whatever happens with a wider contract, it's hard to see how the wider preventive healthcare agenda would benefit from driving GPs out of delivering flu jabs. So that's an area that the government surely needs to look at.
Yeah, definitely. Obviously, it's not really clear what all this is going to mean in terms of the actual contract. But I mean, I also think what we could be talking about is some sort of shift in how childhood vaccinations are delivered, which is something that's been on the cards for a while, hasn't it? At the end of 2023, NHS England published a vaccine strategy, which suggested neighbourhood teams could take on delivery of vaccinations, particularly delivery of childhood vaccinations. That document is really careful to emphasise that general practice remains at the heart of delivering vaccinations, particularly for childhood immunisations, where they have historically obviously been very successful. However, the strategy argues that relying only on GP practices, as is currently the case, around traditional opening hours potentially leaves gaps in coverage. So it suggests the role of GPs could be supplemented by other locations and other providers. So NHS England has really already suggested that vaccinations could be delivered in pharmacies, shopping centres, supermarkets, family hubs, and potentially also, hospitals via outpatient departments. That strategy also encourages, a wider mix of staff delivering jabs. And we actually haven't seen any major shift on this, despite that strategy being published in 2023, when it comes to childhood vaccinations, apart from a very recent change that will see health visitors in some areas where vaccine coverage is very low providing jabs. But you could see that might be an area where the government and NHS England could choose as a focus for a neighbourhood approach. This might be one of the things we see in this year's contract that starts to push practices towards working in that neighbourhood way as part of a neighbourhood. What exactly that looks like isn't clear, but it could be that there's something to do with childhood vaccinations that become part of the PCN directed enhanced service, maybe, whether that's, an incentive or something like that, or just a contractual requirement or some explicit, requirement that PCNs need to work with local partners to boost childhood vaccination coverage. You could see that could happen.
I think another factor around that is just that it's yet more uncertainty around a funding stream that practices potentially, or currently rely on. They just need clarity on it. The more that these sorts of changes are being suggested, but there's no clarity, it just creates doubt for practices in terms of what the future holds for them financially.
Yeah, definitely. And I think, there's a lot of concern as well from some quarters of the profession. And the RCGP said this in a recent story we ran about childhood vaccinations. The importance of GP practices being really the cornerstone of this, because it's such an important time where they can have contact with families to do wider health prevention work, to recognise safeguarding concerns if there are any, and all of those things that come with continuity of care from a GP practice. It wouldn't be great, basically, if we lost that kind of thing by having more people delivering vaccinations. But there is a reason why there is this focus on trying to increase childhood vaccinations, because there's some real concerns about how low these levels are in some parts of the country. You mentioned that outbreak in London. It's a pretty serious measles outbreak in Enfield in North London, where vaccination rates are low. In Enfield, 62% of children aged 5 and below have had 2 doses of the MMR jab, but there are some boroughs in London with even lower figures than that, aren't there? You mentioned that campaign, aimed at trying to boost uptake, and you've been looking at vaccination rates across England, haven't you?
The key figure is that one, the WHO target of 95% coverage for child vaccinations. England isn't at that level nationally on any of the key child vaccinations for, at ages 12 months, 24 months or 5 years of age. Some areas are over the target on some measures, but parts of the country are really miles off. And London in particular has really low uptake. 69% of children across London as a whole have had 2 doses of MMR. The next worst area is the West Midlands with 84%. So London really is in a category, all on its own. And as you said, in some boroughs, uptake is really exceptionally low. And 9 London local authorities have vaccinated less than 2/3 of children aged 5 with 2 doses of MMR. And in Kensington and Chelsea, coverage is just under 52%. It's not just MMR by any means. Uptake of other jabs is really falling short in lots of areas. So there's a lot of work to do to turn that around. For anyone who wants more detail, there's a chart on the story on our website that you can go and have a look at.
So that's kind of things we might see in the contract. Of course, the other things we really need to bear in mind is uplifts to funding and how that's going to change, and also any recommendations by the Doctors and Dentists Review Body. And that's the body that makes recommendations on all doctors' pay. And again, we're expecting that imminently. It could well be out next week. This time last week, the government announced that it would back the recommendations of the NHS pay review body, which will give NHS staff in England paid under the Agenda for Change framework a 3.3% pay increase in 2026-27. I mean, nursing representatives and other trade unions have branded that an insult, arguing it's below inflation. But Health and Social Care Secretary Wes Streeting said it was over and above the 2.5% increase that the government had initially budgeted for. And we know the government's evidence to the DDRB said that doctors, including GPs, should also only receive a 2.5% increase in the coming year. But obviously, it remains to be seen what the DDRB actually recommends. The government has backed that NHS staff pay rise, so it seems quite likely it will back whatever the DDRB recommends as well, but who knows? And it's not clear what pay rise it will recommend anyway. I think one thing to mention here is that this is the first time for 6 years that the pay review body has reported back in time for the government to agree the pay rise and for it to be in people's pay packets from April. In previous years, it's been much later in the year that the pay increases have been agreed, and then they have to be backdated. It's pretty unfair for staff given lots of costs, including council tax, income tax, and all those sorts of things change in April. And I think we can assume that any government decision about the DDRB recommendations and the GP contract will likely come out quite close together, if not at the same time this year, which means practices have a much clearer idea what they are working with in terms of funding for 2026-27. From the start of the year, unlike this difficult situation where they're thinking we might get some money, we might not, how much is it going to be, and it doesn't come through till much later. The other thing to point out about this is although staff in general practice are not paid under Agenda for Change, that pay scale is used to determine the amount of reimbursement primary care networks receive for the staff they employ under the Additional Roles Reimbursement Scheme. And in previous years, those reimbursement rates have been increased in line with Agenda for Change, so we can probably expect to see that happen again this year. What's not certain, though, is whether the pot of money each network receives under the ARRS will be increased by enough to cover any pay rises that PCNs feel they need to give. Sometimes it has been increased, sometimes it hasn't, so we have to wait for more detail about that. Obviously, with all of that, there are a lot of other things that are also up in the air, aren't there, Nick? Particularly around neighbourhoods and what's going on with all of that and what they mean for PCNs. Funding for networks now makes up a huge amount of the money that general practice receives. Practices are basically as reliant on that as they are to the core GP contract, aren't they now?
Yeah, an accountant I spoke to recently said that when practices get the detail of next year's contract, probably in the next week now, as we've said, in many ways it could be almost meaningless when it comes to working out what it means for their overall financial position. As you said, lots of the funding for general practice now comes from enhanced services, not least the PCN directed enhanced service, which is a kind of bolt-on to the GP contract that governs practices' participation in PCNs. There's been a lot of speculation about neighbourhoods taking over control of a lot of that enhanced services funding potentially. Also questions about whether they'll effectively replace PCNs. And that means a lot of doubt over funding streams that practices are totally reliant on to remain financially viable. So even though practices will, of course, be desperate to find out what next year's contract means for their global sum funding, the payments they receive through the core contract funding formula, they'll still have lots of questions about what neighbourhoods are going to mean down the line for other elements of the money they rely on to operate, and that might not be clear for some time to come.
You mentioned earlier we are expecting some guidance on neighbourhoods any day now. Do we know what that will cover?
We don't have a lot of information on that, but what we're expecting is that model neighbourhood guidance will be published this month. NHS officials have alluded to that a couple of times publicly in recent weeks, so it does seem fairly likely to come soon, round about the same time as the contract announcement, potentially. But I think what we're likely to see from that guidance is more along the lines of the broad vision for neighbourhoods and the overarching aims. And it's less likely to provide the detail on contracts and funding, and therefore exactly what their relationship in that sense will be with PCNs, practices, and so on. Like we've said, basically that means that some of that uncertainty around the financial implications of neighbourhoods and the changes they're going to bring is still not going to be clarified just yet.
Yeah, it's getting a bit late now, isn't it, really, for any of these new contracts to potentially come in from this April. I have seen some speculation in some quarters that what we could see maybe is this framework sort of setting out how neighbourhoods should start working together across 26-27, and maybe the actual contractual things like those single neighbourhood contracts and multi-neighbourhood contracts might not really be in existence in any meaningful way until April 2027. And that feels like it probably is quite likely given where we are in the year and what could happen in the next couple of months. It seems more likely that those contracts might not be around until much later than this April. The other story you wrote recently that relates to all of this is what could happen to GP premises that are owned by NHS Property Services as we see this shift towards neighbourhoods. What was that all about?
Yeah, I should probably explain what NHS Property Services is, first of all. It's a company wholly owned by the Department of Health and Social Care. It was set up just over a decade ago to manage NHS-owned property. And about 1,000 GP practices in England operate from premises that it owns, just under 1 in 6 practices nationally. And there have been long-standing issues for many of the practices in those premises for quite some time, from about 2016. NHS Property Services began sending some of them really big bills for service charges, up to 6 figures in some cases. So this was new charges that practices somehow had to find the money for. And that's an issue we've written about a lot. There have been, legal cases and so on around all that stuff. But the latest issue is that the government has published a new set of rules that could mean ownership of these premises shifts to NHS trusts, for example, as part of a plan to accelerate the shift to neighbourhood level integrated preventative care. So basically, if hospital trusts can make a case that taking over control of premises that some GP practices currently operate from would, help the move towards neighbourhoods, then that might swing it.
What do GPs think about this idea? I can't imagine that they're very keen on it.
Given all the issues with service charges and so on that I've just talked about, and some of those charges were so big that they threatened to push practices out of business, for example, really massive problems attached to the way those service charges were introduced and the magnitude of them. And, you might think that GP practices would welcome a change of any sort to get away from that. But the reaction I had from some GPs, it looked like jumping from the frying pan into the fire. One LMC I spoke to said trusts taking over practice premises could give them the power to demand a change in the way practices use those premises. So, for example, maybe pushing them to give up space to bring in other services, for example. So on the flip side, some of this could enable trusts to take over buildings that could become neighbourhood health centres in future. So potentially it's an avenue for trusts to take control of something like that, find the funding to do up some of those existing NHS properties that are probably in disrepair at the moment if they're not being used. And that may not be all bad, but it's something LMCs and practices in NHS Property Services premises at the moment are really going to have to watch closely.
And finally, to wrap all this up, all these things we've been writing about over the last couple of weeks to do with contracts and stuff, the other thing we're waiting for further details on is the review of the GP funding formula. Obviously, that formula is probably not going to change from this April. It's quite likely that change would come in as something that would be tacked onto a much bigger contract overhaul that we're expecting before the end of this Parliament. We don't have any details of exactly what that review is going to recommend at the minute, but there are people who are worried about what it will say, aren't there?
One of the key issues a review of the funding formula might look to address is the fact that currently practices in deprived areas tend to receive less funding per patient but have more patients per GP. But when there are changes to funding, a big worry for practices is that there could be winners and losers from any change. And that's something the BMA is very worried about. There was a debate in Parliament recently that touched on some of the same concerns. So Karen Smith, who's one of the current health ministers, said in the debate that practices in deprived areas receive nearly 10% less funding per patient on average under the current funding formula, but have greater health needs and higher patient to GP ratios. So that's clearly unfair. I think that unfairness is not in doubt, but the fear is that the solution could be equally unfair or unfair in a different way. The BMA, for example, wants an overall increase in funding to come at the same time as any change in the formula to make sure there's what's called a rising tide. And the idea there is that effectively all practices see their funding increase, but some practices go up more than others, as opposed to a scenario where, a change in the funding formula means that some practices see a massive loss in funding and others see a big gain. It seems like MPs basically are worried about something similar, but maybe in this case for slightly different reasons. So this debate covered concerns that with a shift to funding based on deprivation, current weighting for rural practices might be lost, and that basically practices in those areas could lose out. So there's some doubt over how the changes will work. Different groups are worried that they could turn out to be the losers. And I think the problem is that with the BMA frozen out of the negotiations or the review of the funding formula because of ongoing dispute with government at the moment, and in the context of the government saying it just doesn't have all that much money to throw around at the moment, there's a lot of worry about just how badly some practices could fare out of all of this.
Yeah, so obviously we're expecting quite a lot of developments over the next couple of weeks around the GP contract. It wouldn't be a surprise if next week we see something about the contract, potentially DDRB as well, and also that guidance on model neighbourhoods. So we've got a lot to cover. I think we talked on the last news podcast, didn't we, about that BMA webinar, and they indicated that basically what will happen from their point of view once the contract comes out is that they will be expecting to have a referendum and put it to the profession about whether or not they support this contract. And then, obviously spinning off from that, we could see further collective action going on. So basically, the next 2, 3, 4 weeks are going to be pretty crucial for the profession in England and about really set up what could happen and how, I guess, the profession's future relationship with the government continues in this next financial year, which, as we know, will be a really critical year for how neighbourhoods develop and how the government tries to get the NHS to change to this new model. So pretty key few weeks coming up. So do keep an eye out on GP Online for updates on all of those things.
I think another factor is that because this year, like we've been saying, it seems likely that the DDRB recommendations could come at the same time as the contract package itself. Last year, for example, the contract package came, GPs weren't happy, BMA wasn't happy with the increase to core funding that came with that. But they kind of held fire for a while until the DDRB recommendations came out quite a bit down the track. What it means this time, in a way, if the DDRB recommendations come at the same time and they're not happy with them, and based on what we've seen from the Agenda for Change recommendations, they're quite unlikely to be happy with them, it means that things will kick off straight from the start. So, even before the start of the next financial year, there could be sort of moves towards, things like you talked about, like a referendum and an action ramping up again.
Before we go, we've just got time for our good news story, which this week is about some award-winning practices and GPs in London. And I'm joined by our senior reporter, Kimberley Hackett, who went to the awards ceremony. Hi, Kimberley.
Hi, Emma.
So what were these awards all about and who were the winners?
So the London General Practice Awards are run by London-wide LMC to help showcase GP practices' hard work across the capital. It's a really nice afternoon event held in the Terrace Pavilion at the House of Commons, and it was nice to see practice teams from across London come together to celebrate each other's work over the past year. There were a mix of general practice roles recognised across the 13 categories, and I was able to speak to a couple of the winners at the event. Dr. Emma Rowley-Conway won the Long Service Award. She said it was nice to have received recognition for her 35 years working as a GP. She also said she's seen an enormous amount of changes in the profession over the years, but one aspect that has really stood out to her is the digital innovation. She thinks it's a really good tool to help empower patients. Another winner was the Springfield Park PCN, who won the Nursing Team Award. The PCN is in an area that historically has struggled to reach its MMR vaccination rates, but in 2025 the PCN managed to improve their MMR coverage, delivering 2,584 MMR vaccines. And we'll have a case study on GP Business about how the PCN managed to do this. In addition to the several GPs who won awards, other winners included practice nurses and practice managers.
Thanks, Kimberley. We'll put a link to the London-wide LMC's page with the winners on there and the notes for this episode. Well, that's it for this week. Thanks to Nick and Kimberley, and thank you for listening. I'll be back next week when I'm speaking to the co-chairs of the BMA Sessional GP Committee, Dr. Amy Small and Dr. Kim Rollinson, about the challenges facing salaried and locum GPs, what needs to happen to address the jobs crisis, and what the BMA is doing to support and represent sessional doctors. So please do join me then. In the meantime, don't forget you can keep up to date with all the latest news affecting general practice and access lots of other resources on our website at GPonline.com.